So our next lecture is cervical cancer. So why it's important to talk about cervical cancer? Because only in the US around 4,000 people die every year from cervical cancer, 10,500 new cases every year. Half of the diagnosed patients between the age of 35 and 55, which means they are young patients, 20% of them above the age of 65. Rarely we find cervical cancer below 20. The non-invasive form is 4 times more common. That means the precancerous stage is 4 times more common than the cancer stage, which gives you a golden opportunity to treat it before it becomes cancer. There is 74% decrease in the death from cervical cancer between 1955 and 1922 in the US. That's because of the national screening system by pap smear. Death rate continued to decline by 2% per year. The lifetime probability of developing cervical cancer is 1 in 128. The cervical cancer starts from the lining of the cervix, from the epithelium of the cervix. The cells change from normal to a precancerous stage, which is basically they have dysplasia, then to cancer. This process takes about 10 years. This gives you the golden chance to pick up the disease at early or the precancerous stage and to treat it before it becomes cancer. How you do that? By regular screening. If we have a national pap smear test, screening test, we'll pick most of the cases before it becomes cancer. There's 3 types of cancer: squamous cell carcinoma, which originates from the squamous epithelium of the cervix. This covers the ectocervix, the outer side of the cervix. It accounts for 80% to 90% of the cases, which is the most common type. The other type is adenocarcinoma. This comes from the canal of the cervix, where you have columnar epithelium, which has a gland. This accounts for 10 to 20%. And the third type is the mixed carcinoma. Signs and symptoms. Vaginal bleeding. Any abnormal vaginal bleeding is a symptom of cervical cancer until proven otherwise. Any type of bleeding. Before period, after period, in the middle of the period, premenopausal, postmenopausal, any bleeding is a symptoms of cervical cancer. If you have a lady with bleeding, always examine the cervix. Pain during intercourse, another symptom. Type of patient, usually multiparous, low socioeconomic class, poor hygiene, prostitutes, and low incidence in Muslim and Jews. The multiparous here in the Western type of the world usually are ladies with multiple sexual partners. So as we said, type of patients, we said multiparous is a type of patient for which is might develop cervical cancer. This refers to the Western type of life in the state, in the UK. Women who have many children usually associated with multisexual partners, and they are more at risk of cervical cancer. This is not the same in our societies because we have conservative societies. All our women have many children, but they have only one partner, one husband. Okay, that is low. That's why we have low incidence of cervical cancer in Muslim and Jew. Right. Symptoms. As we said, any abnormal bleeding, any abnormal discharge is a symptom of cervical cancer. Now, late symptoms with late metastasis is pain in the leg, symptoms from the bladder or from the bowel. Risk factors, the most important risk factor is the human papilloma virus infection, HPV. There is high risk group of HPVs, there's also low risk group of HPV. The most important or the most dangerous two types of HPV is 16 and 18. They account for 50% of the cases of cervical cancer due to HPV, and 90% of the cervical cancer are related to HPV. Sexual behavior, smoking, HIV infection, chlamydia infection, any type of sexual transmitted infection, oral contraceptives. This is especially on the Western world. The teenager girls, when they start taking contraceptions, they are safe from getting pregnant, so they go wild, and that why this can be a risk factor for cervical cancer, not because of the contraceptives per se. Multiple pregnancies, low socioeconomic status, diethylstilbestrol, and family history. These are the high risk and low risk group of HPV. As we said, the most important two and the most common two of the high risk group is 16 and 18. From the low risk group, the most important two is 6 and 11. These are usually responsible for the wart lesions. How cervical cancer or high HPV, any risk factors of cervical cancer cause cancer, is by inhibition of the tumor suppression gene. This genes protect you against developing cancer. If you inhibit this, then you'll develop cancer. This is the layers of epithelium of the cervix, and here this area is the cells with changes, with dysplasia. This is the normal layer, and here we have more dysplastic cells, so we have mild dysplasia. The changes cover only about 1/3 of the whole thickness of the epithelium. If it's become 2/3 to full thickness, this is grade 2 and 3. If it's past the basement membrane, this is invasion, microinvasion, and carcinoma in situ. This is how the cervix looks on colposcopy examination. This is the normal cervix. Here's a low grade CIN1. Here the high grade CIN2 and 3, and here is cancer. How prevent cervical cancer? By avoiding the risk, especially HPV test. Also having regular pap test. You capture the disease at early stage or precancerous stage, and you treat it. We should do pap smear test 3 years after. We should start 3 years after the first intercourse or by the age of 21, and you can have annual test. So how we detect the disease? By pap smear, cervical cytology. Pap smear is basically smearing the test, taking few cells from the cervix and examine this under the microscope. This might reveal normal cells or atypical squamous cells or squamous intraepithelial lesion or even squamous cell cancer. Diagnosis by history. Most of the women are asymptomatic, and most of them presented with abnormal cervical smear. So if you have a regular cervical smear, then even if you don't have symptoms, we might capture the disease at the very early stage and treat it. Or they might come with abnormal bleeding. As we said, any type of abnormal bleeding. You should consider this as a cause of cervical cancer unless proven otherwise. So examine the cervix basically. Examination is speculum, coscospeciculum, and look at the cervix. you might find a normal cervix, you might find a mass, ulcerating, fungating mass in the cervix. Okay, if you find a mass and you think it's cancer, don't do pap smear, take biopsy from the mass. Okay, you can examine the bladder and the rectum. If you have any doubt about any mass, do colposcopy. Colposcopy means examining the cervix by magnifying glass. You increase the size of the picture by 10 times, so you can see the lesions more clear. Moreover, during colposcopy, we add a chemical, acetoacetic acid, which make the lesions, the abnormal lesions, look white. The more whiter the lesions, the more likely that it is abnormal. So you can distinguish which area is abnormal. You can distinguish or you can decide where you want to take your biopsy from. Okay, so colposcopy, examine the cervix, see the abnormal lesion, take biopsy. You can also do endocervical curettage, especially if you think there's something in the canal, or you can do cone biopsy. So cytology, colposcopy, histology. This is the colposcope, this is speculum, cuscospeculum, and this is taking a pap smear. The stage of the diseases is 5 stages according to FIGO. Stage 0 is carcinoma in situ. Stage 1 is the lesion in the cervix but hasn't spread outside. Stage 2, it has spread to nearby areas but not leaving the pelvic areas. Stage 3, the cancer has spread to the lower part of the vagina, and 4, is spread to the bladder or the rectum. Right. If you find a cancer, any type of cancer, the next thing you want to do is to stage the disease so you know how to treat it. How you stage cervical cancer? Examination under anesthesia, bimanual palpation, PV, PR, cervical biopsy, uterine biopsy. You might do cystoscopy, proctoscopy if necessary. This is more detailed staging of the disease according to the extent and depth of the lesion. So the size and the depth of the lesion. Preoperative evaluation, review the history, general examination, examine for anemia, lymph nodes, renal area, liver, size of the liver, edema. You can do laboratory test like CBC, liver function test, kidney function test, urine analysis, tumor markers. You can do imaging like X-ray, abdominal X-ray, IVU, CAT scan, MRI, ultrasound, lymphography if necessary. How the disease spread? Either direct or by lymphatic or dissemination. Direct to the uterus, vagina, parametrium, and bladder and rectum. Lymph nodes to the lymph nodes of the pelvis or the abdomen. And dissemination, it might spread and block the ureter or even the uterus. 5-year survival rate is 92% for earliest stage and 70% for all stages combined. Treatment. The treatment is either surgery, radiation, or chemotherapy. Now, for the pre-invasive cancer, you can have cryosurgery, laser surgery, or colonization. For invasive cancer, simple hysterectomy for very early stage, stage 1 and 2A, removal of the body of the uterus and the cervix, or you can have radical hysterectomy and pelvic lymph node dissection. Radiotherapy, you can have radiotherapy for stage 2B and 3 and chemotherapy for stage 4. The complication of surgery is usually big surgery with the common complications of bleeding, injury to the surrounding organs, bladder, ureter, bladder dysfunction, fistula, lymphocele, and shortening of the vagina. The choice of treatment depends on the stage of the disease, on the type of the lesion, age and fitness of the patient, and experience and resources available. The surgery has several advantages over radiotherapy. First and more important thing, it allows preservation of ovaries and sexual function, because radiotherapy usually doesn't distinguish between ovary and other tissue, so it might damage the ovary. It's also a very common cause of vaginal stenosis, so sexual function is a problem after radiotherapy. Psychological feeling of removing the disease from the body. Patients feel better after surgery because psychologically they think that you remove everything, because you actually open and remove the cancer. While radiotherapy, the cancer is still there and you hit it with radiation, hoping that you will destroy it. Besides, surgery is more accurate in staging and prognosis. Would you do radiotherapy after surgery? Yes, if you have positive lymph node in the histology report, or if your tumor in the histology report is very close to the margin. That means that you might have missed something. If you have this, then you need to do radiotherapy. Radiotherapy as a primary treatment for stage 2B and 3 can be radical radiotherapy, external radiation, or intracavitary radiation. In some cases of stage 2A and B, radio and chemotherapy might be combined after hysterectomy. The prognosis depends on the stage of the disease, the most important factor, and the age and fitness of the patient, type of tumor, and adequacy of treatment. If you have recurrent, how you will manage it? If your first treatment was surgery, then you can do a local radiation, or you can have pelvic exenteration. Pelvic exenteration is removing everything in the pelvis, diverting the bladder and the bowel, and basically emptying the pelvis, removing the bladder, rectum, peritoneum, everything. Distant diseases treated by chemotherapy. Glandular tumor are not detectable by screening and associated with skip lesion, so the treatment requires more radical surgery. How you follow up the patients? After the surgery or the radiation, you can give the patients vaginal dilator to avoid vaginal stenosis. In the premenopausal patients, you can start them on HRT. We'll see them after 1 month. If everything fine, you check them every 3 months for 2 years. Then after that, every 4 months for the 3rd year. Then every 6 months until 5 years. After that, yearly all their lives. The overall 5-year survival is 80% for stage 1, 50 to 60 for stage 2, 30 to 40 for stage 3, and 4% for stage 4. What's new in cervical research and treatment? HPV testing. Now it's applicable, and there's 2 types of HPV vaccines which cover 16 and 18, or another one which covers 16, 18, 6 and 11. HPV testing, we use HPV testing now combined with the pap smear for screening. And if it's negative and the pap smear is negative, then you can increase the period of screening instead of every 3 years, for example, to 5 years. Radical trachelectomy procedures. These are procedures which removing only the cervix, leaving the uterus behind. Other clinical trials. That's all about cervical cancer. Thank you.